All right, hi again. Now moving on from the ovaries into the uterine tubes and the uterus. The uterine tubes, which I've already said, can be called fallopian tubes, although we're trying to get away from eponymous nomenclature. And for a more biological description, you would call them the oviduct. And you can use these interchangeably. Females have two uterine tubes. They extend laterally from the uterus, so you can see, like, this is the uterus right here. Here's the ovaries, and then here's the start of the fallopian tube, and you can see it's a windy, windy path that takes you into the uterus. These fallopian tubes lie within the folds of the broad ligament of the uterus, right? Remember, that's like the Batman wings. The primary function of the fallopian tubes is to, one, be a route for sperm to reach the secondary oocyte. The secondary oocyte will be somewhere in the fallopian tube when the fertilization takes place. So the sperm has to travel through the vagina, through the uterus, through some region of the fallopian tube where it will reach the oocyte for fertilization to take place. So that's one function of the uterine tube. The second, obviously, is to help the zygote once fertilization has taken place. Once fertilization has taken place and you have a zygote, or fertilized ovum, it's going to implant in the wall of the uterus. So the second function of the fallopian tube is to move the zygote from the fallopian tube into the uterus. You don't want to have the zygote trying to implant in the fallopian tube. That would lead to an ectopic pregnancy. So starting at the ovaries over here and then working proximally, so towards the uterus, we start with the infundibulum of the uterine tube. It's shaped like a funnel, and basically its job is to funnel the secondary oocyte as it's expelled from the ovary and make sure it gets captured and caught into the fallopian tube. This is actually pretty remarkable, isn't it? That this is probably one of the most important biological functions in the human body, reproduction, that is. And we are leaving it to a game of chance. We're actually shooting the oocyte out of the ovary and hoping it goes into the fallopian tube. Now, obviously, the fallopian tube is expanded at this region at the start, or at the distal end, which is going to sort of make it easier to funnel and capture the oocyte, but nonetheless, it is getting shot into the pelvic cavity, and sometimes it misses, and the oocyte does not make it into the fallopian tube. That's called a Mittelschmitz. The ends of the infundibulum are these finger-like projections. You see how there's all these little finger-like projections? Actually, it's easier to draw over here. All these little finger-like projections at the ends of the infundibulum. These are called fimbriae of the uterine tube. Only one of the fingers is actually attached to the ovary. Everything else is just free-floating. Like I said, there's not a direct connection between the ovary and the uterine tube, which is actually pretty remarkable, that the ovary is ovulating out the secondary oocyte into the pelvic cavity and not directly into the uterine tube. From the infundibulum, this area right here, the uterine tube will then attach to the superior lateral angle of the uterus right here. The ampulla of the uterine tube is the widest, the longest portion. So this part right here, this sort of windy, windy path, it's about 2/3 of the length of the uterine tube. And then finally at the end, there's this thinner area right here, which is called the isthmus. It's a more medial, short, narrow, thick-walled portion. And you see that, again, it joins the uterus in this superior lateral angle. If we zoom in and look at the histology of the uterine tube, you see something very familiar. You have 3 layers. You have a mucosa. You have a muscularis. And you have a serosa. The muscularis is, as you can see in this picture here, a simple columnar epithelium. There's really 2 cells within that population. There are your simple ciliated columnar epithelial cells, but you also have the second population of cells within there called PEG cells. The PEG cells are non-ciliated cells that have microvilli on the surface, and they secrete this fluid that provides nutrition for the ovum. So the brief period of time where the ovum is in the fallopian tube prior to fertilization or as a zygote, the PEG cells are going to be able to nourish those structures for the short time that they are present within the fallopian tube. The columnar cells with their cilia on their surface are a crowd surfing conveyor belt, like they were in the respiratory tract. All of those cilia are beating in unison, and in doing so, they're helping to move the ovum, the oocytes, into the correct position within the fallopian tube, and then eventually, actually, ultimately move the zygote into the uterus itself. Surrounding the simple columnar epithelia of the mucosa is a lamina propria, again, of areolar connective tissue, exactly like what you'd expect. There are two layers of the muscularis. There's a inner thick ring of circular smooth muscle, and there's an outer thin ring of longitudinal smooth muscle. And these, in addition to the ciliary movements, are going to create peristaltic contractions that will also help move the ovum towards more proximal regions of the fallopian tube, and then ultimately the uterus. And then finally, we have a serosa, and the reason it's a serosa is because this is part of the peritoneum. So the outer layer of the uterine tube is going to be a visceral peritoneum. And then this is a beautiful picture because it shows you just the heterogeneity of the uterine tube epithelium, where you can see in blue here the PEG cells, which have microvilli on the surface and are secreting this nice nourishing fluid into the fallopian tube, and then you have these yellow here, the cilia, that are crowd surfing the ovum and the zygote through the fallopian tube. So we're going to talk about this in a lot more detail later on, but basically I just want to show you the events of early development. What we're talking about in the previous lecture was the mature follicle here expelling the secondary oocyte into the fallopian tube. This will travel some length through the fallopian tube where it will encounter sperm, and if the sperm penetrate, you end up getting a fertilized zygote, which will then go through a series of developmental changes. Ultimately, this is all like the kind of embryo stage of development. So day 1 post-fertilization, day 2, day 3, day 4, day 5, day 6. And by the time you get to day 7 or day 8 or day 9, the zygote is much more developed and is now inside the uterus rather than the fallopian tube, and will start implanting. This is the location of the uterus. Of course, the function of the uterus is to act as a pathway for sperm to reach the uterine tube, and then secondly, it is also the site of implantation of the blastocyst. So in other words, it's where the embryo and the fetus is going to develop. The uterus is situated between the urinary bladder, in yellow here, and the rectum, in red here. The size and shape of it, it's sort of like, imagine an upside down pear. You can't really see that from this particular section, of course. Its size can vary, so women that have just had babies have a larger uterus than those who have not. And when sex hormones are low, such as you would see in menopause, for example, the uterus will atrophy a bit. In other words, it will get smaller, in fact. There are 3 major anatomical subdivisions of the uterus. We have the fundus, which is the dome-shaped portion at the superiormost region. It's actually above the uterine tubes. We have the body of the uterus, which is the sort of central tapering region. And then you finally, at the most inferior region, have the cervix, which is an inferior narrow portion of the cervix that empties out into this region down here, which is the vagina. There is a small isthmus that connects the body of the uterus and the cervix. And it's about 1 centimeter long. You can see it right there. Then within the uterus itself, we have a large uterine cavity, which is the interior of the body of the uterus. And we also have the cervical canal, which is the interior of the cervix. There is also the internal os and external os. The internal os right here is where the cervical canal opens up into the uterine cavity, and the external os is where the cervical canal opens up into the vagina. Right? So here's your cervical canal, and then if you go that way, you go through the internal os, and if you go that way, you go through the external os. The uterus normally projects anteriorly, so towards the front of your body, and superiorly over the urinary bladder. So you can see here, here's the urinary bladder, and then here's the uterus. So it goes anteriorly and superiorly over the urinary bladder, like so. So it kind of sits on top of the urinary bladder, like so. This is referred to as anteflexion, which is anteroflexion of the uterus. And as a result of this orientation, if this is the cervix down here, that's the vagina. This is the cervix right here. The cervix is pointing in this direction, so it's projecting inferiorly and posteriorly. And you'll notice that it actually enters into the vagina, which is this part right here, at virtually a right angle at 90 degrees. As we talked about in the previous lectures, several ligaments help maintain the position of the uterus, and these are derived from either the parietal peritoneum or, in some cases, fibromuscular cords that you don't need to worry about. These include the broad ligament. We also, which we haven't mentioned, the uterosacral ligaments down here, and the cardinal ligaments, which are not shown on this particular slide. I'll show you in the next one. And the round ligaments, which I'll show you as well. Again, these are double folds of the peritoneum, and their job is to attach the uterus to either side of the pelvic cavity. So that's the broad ligaments. Here's the uterosacral ligaments. These are right here. These are also called peritoneal extensions. They lie on either side of the rectum and connect the uterus to the various other regions of this pelvic body, anteriorly, I should say. The cardinal ligaments are located inferior to the bases of the broad ligaments. So here you can see the cardinal ligaments coming out right here, and they extend from the pelvic wall to the cervix and the vagina. Round ligaments are bands of fibrous connective tissue between the layers of the broad ligament. You can see them right here, and you can see the broad ligament kind of draped over top of it. They extend from a point on the uterus just inferior to the uterine tube to a portion of the labia majora of the external genitalia that we'll talk about in a subsequent lecture. Although normally what you would expect is that these ligaments maintain the anteroflexed position of the uterus, they also allow the uterine body enough movements so that the uterus can be mispositioned. What you're seeing here in this picture here is something called a retroflexion, in which the uterus is tilted, instead of anteriorly, is now tilted posteriorly. This is harmless and can often occur without cause, although it's very commonly found after childbirth. Uterine prolapse is also possible, and this may result from basically weakening of those supporting ligaments, and also the musculature of the pelvis weakening as well. This is often associated with age or disease, a traumatic birth delivery, vaginal delivery, chronic straining from coughing or difficult bowel movements, or actually cancers in this region as well. So there's different regions of this. This isn't in your objectives, I don't think, but it's kind of interesting. This is a mild prolapse in which the cervix is right down here. Remains within the vagina. Stage 2, which is marked, the cervix is now actually protruding from the vagina, and in stage 3, the entire uterus, in fact, is outside of the vagina. This is called a complete uterine prolapse. Treatment for this could be as simple as exercising, using a stool softener, getting the cancer treated. There's actually physical devices that you can put in there to hold the cervix up as well. In terms of histology, there are a number of layers to the uterus. We're going to start from the outside and work our way in. The outer layer is called the peritoneum, the parametrium, it's the outer layer. And it consists of a serosa, which is the visceral peritoneum, a simple squamous epithelium combined with areolar connective tissue. The parametrium laterally is what gives rise to the broad ligament, actually. Myometrium is the middle layer, and it consists of 3 layers of smooth muscle. There is an inner longitudinal layer, there's a middle circular layer, and there's an outer oblique layer. And these collectively are the muscles that push the baby out during delivery. The endometrium is the inner layer. The real name of the game here is it's heavily vascularized. It contains some sort of epithelium that we'll talk about at length later on with associated glands, and also has a lamina propria, which consists of areolar connective tissue. The parametrium is the outer layer of the uterus. Again, the outer layer of the uterus is a simple squamous epithelium and areolar connective tissue. Laterally, as I said, it becomes the broad ligaments, which you can't see in the sagittal section here. Anteriorly, it becomes, it covers the urinary bladder and forms a shallow pouch, right? So you can see the parametrium here, and you can see anteriorly it makes this really tiny pouch down here, and that's called the vesico-uterine pouch. And posteriorly, right here, it makes a second pouch called the recto-uterine pouch. And that is the most inferior place, actually, in the pelvic cavity. So here's looking at the histology of the uterus. You can't actually see the parametrium. The parametrium would be down here. But you can definitely see the myometrium. That's this large red area right here and in here. The innermost layer, which we want to talk about, is, of course, the endometrium. And the endometrium in this place can be found in sort of 2 layers, depending on where you are. Again, the endometrium is highly vascularized. It has 3 layers. At its innermost layer, it has a simple columnar epithelium, which is consisting of ciliated and secretory cells, a layer of lamina propria, which is areolar connective tissue, and endometrial glands that are developing as invaginations of the luminal epithelium. I'll show you one of those on the next slide very close up. But I can see a few on this slide as well. These invaginations actually in some cases penetrate almost all the way down into the myometrium. The endometrium, as I said, is divided into 2 layers. One is called the stratum functionalis, which is this lighter layer up here and up here. And then there's also a lower layer underneath it. Oh, sorry, here's your stratum functionalis. In certain stages called the stratum basalis. The stratum functionalis is what falls off during menstruation, so it has to be repeated every uterine cycle. The stratum basalis down here and down here is a permanent layer that gives rise to a new stratum functionalis once each cycle. So this is where the stem cells for the stratum functionalis are located. I'm zooming in now totally on the endometrium, and what I'd like you to be able to see is first, okay, you have the lumen of the uterus. We have the first layer being a simple columnar epithelium, underneath which we have the stratum functionalis, which may or may not be present, and underneath that we have the stratum basalis, which is always there. And here you can see this invagination of the luminal space deep into the stratum basalis. And that is, again, your endometrial gland, which is going to be secreting things to help nourish the zygote as it's developing in its fetal and embryonic stages. Embryonic predominantly stages. We have a large amount of vasculature in the uterus. You don't really need to know this in too much detail for this course. There are uterine arteries, obviously, which are coming in to feed the uterus proper. The uterine arteries are actually branches of the internal iliac artery that supplies the uterus. The uterine arteries break off into branches called arcuate arteries. So here's your uterine arteries, and then you get arcuate arteries. And these are arranged in a circular fashion around the myometrium. So you would actually kind of imagine them looking like this if you could see through this. And these arteries then branch off further into what we call radial arteries that penetrate very deeply into the myometrium. And then before the radial arteries reach the endometrium, they divide into, and this is what we're focusing on here, they divide into two separate arterioles. So here's the radial artery going in right there, and we branch off into straight arterioles. And if the stratum functionalis is present, you will also start to see these spiral arterioles. The spiral arterioles are what supplies the stratum functionalis, and they're going to, as a result, change markedly through the menstrual cycle. The straight arterioles are more permanent because they are supplying the stratum basalis with the materials that the stratum basalis needs to regenerate the stratum functionalis. The blood leaving the uterus, it's not shown on here, I don't think. Oh, well, you can see a little bit of a vein down there. The blood leaving the uterus is drained by uterine veins, which then feed into the internal iliac veins. The secretory cells of the mucosa of the cervix produce a secretion called cervical mucus. You produce quite a bit of it, 20 to 60 mils a day, and it consists of water, glycoproteins, lipids, enzymes, and salts. During ovulation, the cervical mucus appears less viscous and as more alkaline. This is to make it a sperm-friendly environment. Sperm are going to like this high pH. It's actually about pH 8.5. So pretty basic. And the lack of viscosity will mean that the sperm can swim better. They actually, in addition to that, are actually providing an energy source. So the cervical mucus contains a source of energy for the sperm. At other times, the mucus in cervical mucus is much more viscous and will actually do the exact opposite and form a cervical plug that will prevent the sperm from being able to enter into the uterus in the first place. They are also involved in protecting the sperm from phagocytes so that they don't get killed by your own immune system, and also from the relatively acidic chemical environment of the uterus and the vagina. They may also, the cervical mucus, participate in this process called capacitation that we'll talk about in a couple weeks' time. Capacitation, briefly, is just a series of functional changes that the sperm undergo in the female reproductive tract before they can properly fertilize a secondary oocyte. With that, that's the end of our uterus and uterine tube lecture, and then next class we'll talk about the vagina and the remaining external structures of the female reproductive tract. I'll see you then.